Hi, I'm Robert Parisian. I'm an orthopedic sports medicine surgeon at the Icahn School of Medicine at Mount Sinai, and I'd like to discuss anatomic single bundle ACL reconstructions with utilization of the modified anteromedial portal technique. This is actually a talk that I gave recently at the New York State Society of Orthopedic Surgeons, where we discussed and had a panel discussion and a great conversation with regards to femoral tunnel drilling techniques. Tibial tunnel drilling has been relatively standardized with a few variations. However, there are multiple variations in the femoral tunnel drilling technique, and the modified intermedial portal technique is my preferred technique, and I'll discuss why. These are my disclosures. I don't have any financial disclosures. However, I am on the Council of Delegates of the American Orthopedic Society for Sports Medicine. I'm the associate editor for the Journal of Cartilage and Joint Preservation. I also serve on the editorial boards of Arthroscopy, Sports Medicine and Rehab, as well as the Journal of Sport Rehabilitation. And I'm on the research committees for both the AOSSM and ANA, the Arthroscopy Association of North America. Also on the Surgical Skills or Learning Center Committee for the Arthroscopy Association of North America, the Media Committee for the Society of Military Orthopedic Surgeons, and the Board of Trustees at Athlete Soul and Advisory Board member to Concussion Legacy Foundation. Now, I think it's important when you're going through a talk and you have someone who's discussing a topic to really understand what their background is. So here's my background, and my training was at residency in orthopedic surgery at Boston University, as well as my first fellowship in sports medicine and shoulder surgery there at Boston University, where I would utilize, as far as the drilling techniques are concerned, both the anteromedial portal technique as well as the outside in guided retro reaming technique that we'll discuss as well. Now, at the University of Pennsylvania and the Penn Center for Cartilage Repair utilize anteromedial portal techniques, as well as the guided outside in retro reaming technique, as well as outside in technique where you actually ream from the lateral femoral cortex and place your screw through the lateral femoral cortex when you make an incision laterally on the knee. And so I utilize all these various types of femoral drilling techniques, which I think are very important, because even though you might have your primary technique, you also want to be able to have some other options in case that primary procedure, for whatever reason, isn't going exactly as planned, that you have some other tools in your arsenal to utilize. And then I did my final fellowship at Harvard Medical School in minimally invasive hip surgery. So I think if we're discussing ACL surgery, we have to discuss this gentleman here, who is a mentor of mine and a mentor of many. I've known Dr. Fu for over 15 years. Again, he was a wonderful man and a wonderful person within the orthopedic surgery community, as well as the sports medicine community specifically. And he really was a pioneer and godfather of what we do know anatomically and biomechanically with regards to the ACL. So at one point in time, Dr. Fu had said, anatomic ACL reconstruction is defined as the functional restoration of the ACL to its native dimensions, collagen orientation, and insertion sites. Now, a little background on the ACL. It is one of the most commonly performed procedures in sports medicine, ACL reconstruction. There are about 200,000 performed per year. The female to male ratio is about 5-to-1. And that's really, we regard landing biomechanics, neuromuscular activation patterns, as well as the quadriceps dominant condition in females, which is why they may place them at increased risk of ACL rupture as compared to males. Now, looking at form and function of the ACL, provides about 85% stability with regards to anterior translation of the tibia. It's a secondary restraint to tibial rotation, as well as varus and valgus stress. And its anterior translational strength is about 2,200 newtons. Now, there are two bundles that make up the ACL. There's an anteromedial bundle and a posterolateral bundle. And again, a lot of the work from Dr. Fu going through and investigating and teaching us about these two bundles and about double bundle fixation. So the anteromedial bundle is taut in flexion. It's the primary restraint to anterior tibial translation. So think about your Lachman examination and your anterior drawer testing. The posterolateral bundle is taut extension. It provides rotational stability. So again, think of pivot shift testing when you think of your posterolateral bundle. Now, looking at form and function, we need to distinguish between anatomy, normal anatomy, and arthroscopic anatomy. It's a little bit different. So arthroscopic anatomy, the knee is flexed at roughly 90 degrees. And so you look here in the in arthroscopic anatomy, the top left there, the intercondylar ridge, the lateral intercondylar ridge, the femoral footprint of the ACL is below that. And so again, we'll get into different terminologies about what you call, how we define this inside the knee. But here, the normal anatomy above is anterior, posterior is below, and in arthroscopic anatomy, you may describe that as high-low. If you notice the bifurcate ridge, the lateral bifurcate ridge, that really separates your anteromedial and posterolateral bundles. Looking at arthroscopic anatomy right now, the posterolateral bundle will be closer to us, more shallow, and the anteromedial bundle is a little bit deeper. It's a little bit further back and separated by that lateral bifurcate ridge. I think this gives a better depiction of that. When you're in extension, you can see that, and you look at the anatomy, it's anterior to posterior. When you flex the knee, anterior to what was anterior to posterior in extension is now distal to proximal. So in arthroscopic anatomy, you may describe this as shallow to deep. And the ACL now, as you can see, when in extension, that lateral intercondylar ridge is actually anterior to the ACL femoral footprint. When you flex it, it's still anterior, but when you're looking arthroscopically, it's actually going to be below, or it's going to be low in a high-low direction, and below that lateral intercondylar ridge is the femoral footprint of the ACL, both anteromedial and posterolateral bundles. Now I'm going to discuss two studies that look at the femoral footprint and define the femoral footprint. There have been many more done, but I think these are two that are very well done. This one is a systematic review of 16 studies from imaging and cadaveric evaluations. And again, defining this, right? So B, if you look down in B, this is the anatomic anatomy: anterior femur, posterior femur, and then proximal distal femur. Well, again, when you're looking at arthroscopic anatomy, when you're flexed at 90 degrees, you look at A, you can also describe this as being high-low rather than anterior-posterior. You can describe it as being deep-shallow rather than proximal and distal. And so in this study, they described their femoral tunnel placement in the high-low, deep-shallow anatomic nomenclature for the anatomy when describing the femoral tunnel placement. So if you look at A, the blue rectangle that you see there, that is the femoral footprint, center position of a single bundle reconstruction for the femoral footprint. And what did they find? They found that the normal range of centers of the ACL and the femur ranged from 24 to 37%, again in the deep shallow direction in arthroscopic nomenclature, and about 28 to 43% in the high-low direction. Again, the blue rectangle. And then on the tibia was the tibial footprint, and that was 39 to 46% in the A to P direction. And then B really goes to double bundle anatomy. The blue rectangle would be the anteromedial, and the green and the femur would be the posterolateral bundle. Now, this is another systematic review that was done looking at center femoral footprint anatomy. Dr. Lubowitz and his colleagues, they looked at 20 articles. And in this study, if you look at A there, that is actually the center of the femoral footprint anatomy. B is actually looking at both bundles. So that posterior cluster there that you can see, or the cluster that is going to be in an anatomic anatomy, it's going to be deeper. That is the anteromedial, and then the cluster that's going to be more shallow, that's the posterolateral bundle. And so what did they find in their study? Well, they found that in A, the anatomic centrum of the ACL footprint is 43% of the proximal to distal length along the lateral femoral condyle intercondylar notch. And so again, that's proximal to distal. So it's deep to shallow, 43%, where they found the center of the footprint. They also found that it was 2.5 millimeters anterior to the posterior articular margin. And so if you went to the center of that tunnel, you would have to add the radius, right? From the center of the tunnel, the radius plus 2.5 millimeters. That was a distance to the posterior articular margin, which they found for these femoral tunnel anatomy. So now looking at different techniques, now we understand the anatomy and where the footprint is of the for the ACL. We can look at different techniques. Traditionally, it was the transtibial technique, was a common technique that was performed and still often performed today. What are some strengths? Well, technically easier to perform. You get a longer tunnel length, and you have decreased risk of posterior wall compromise with this transtibial technique. Weaknesses: non-anatomic femoral tunnel footprint, increased rotational instability. So think pivot shift, because you're not reproducing that, recreating that anteromedial bundle as well. That posterolateral bundle as well. And so you have increased pivot shift and rotational instability. Now for the hybrid transtibial technique. This is a technique that's been described more recently, and that it includes an additional guide to utilize this. Some strengths, it recreates the anatomic femoral footprint. You have a longer tunnel compared to the traditional anteromedial bundle, but again, I'm going to discuss the modified anteromedial portal technique. So, right, not the anteromedial bundle, but the anteromedial portal technique. Hybrid transtibial, you also have good anterior translation rotational stability. Some weaknesses, technically challenging. And you have a learning curve with this hybrid transtibial guide. And also you get a risk of posterior wall compromise as compared to the transtibial technique. Traditional anteromedial portal drilling, strength is anatomic femoral footprint, anterior translational and rotational stability. Some weaknesses are you might get a shorter tunnel length, which increases your graft angle. Now, this may increase your graft strain. We don't know the entire clinical relevance completely as of yet. And then you also have some risk of posterior wall compromise. And then I'll get into the modified technique that I utilize. So this is another representation of this, looking at the coronal obliquities. As you can see, the transtibial technique, you have a more vertical tunnel, increased graft coronal obliquity. So straight up and down is 180. So it's increased angle with transtibial, slightly decreased angle with hybrid transtibial, and then the anteromedial portal, traditional one there. And you can see you get a shorter tunnel with that. This is another way in which to look at this. And if you look in the on the AP or the coronal image right there, you can see that the anteromedial and the hybrid transtibial are going to recreate that anatomic footprint for the ACL graft, whereas the transtibial technique is not anatomic with regards to the footprint. Now, as I said, I think I can recreate that increased tunnel length in the hybrid transtibial thing with a flexible reaming system with an independent guide, flexible reamer, the knee at 90 degrees. You don't need to hyperflex, so the anatomy does not get distorted. If you change the angle of that guide, and then you can increase your tunnel length with a anteromedial portal drilling for a modified technique. This MRI study is a wonderful study because it really demonstrates how that can be done. This MRI study looked at anteromedial tunnel drilling versus transtibial tunnel drilling, and they specifically looked at femoral tunnel lengths in ACL reconstruction. If you look at A, this is coronal angles. You can see the knee flex at 90 degrees, such as it would be in an arthroscopy. The yellow line is at 30 degrees, or the orange line, 30 degrees of coronal obliquity. The red is at 45 degrees of coronal obliquity, and the green is at 60 degrees of coronal obliquity. You look at the sagittal. The blue is at 45 degrees of sagittal obliquity, and the yellow is at 60 degrees. And so again, changing that angle, what does that do? Well, this study found that if you position your guide and you get a tunnel that is drilled from an anteromedial portal at 45 degrees of coronal obliquity and 45 degrees of sagittal obliquity, this resulted in a similar tunnel length as a transtibial tunnel technique. Again, recall, transtibial tunnel techniques, you had the longer tunnel, but it wasn't anatomic with regards to the femoral footprint. This can be anatomic with regards to the femoral footprint, utilizing a flexible reaming system with an independent guide, and angling that guide at 45 degrees coronal and 45 degrees sagittal. You can get a longer tunnel, and you can still get a femoral footprint, anatomic femoral footprint from an anteromedial technique. And again, I like this and call this the modified anteromedial drilling technique. And so now, what is my technique? What do I do? So I make an accessory anteromedial portal that allows me to get that obliquity that I need. So I go very medial and I go inferior, as you can see in the red there. For an accessory anteromedial portal, I come right off the distal aspect of the femoral condyle with care taken not to damage the femoral condyle. But you really want to have this angle so that you can get your femoral tunnel, your femoral footprint, and you can get the angle that you need. Now, look at the top image there, and you can see the transpatellar portal. This is a Freddie Fu portal. This is a portal that I think should be utilized. I utilize it for every case. I call it the notch portal, and it allows you to get a fantastic view of the medial aspect of the lateral femoral condyle along the notch. And I'll show you some examples of that. But again, I recommend utilizing this notch portal for your cases. to give you better visualization. Now, this is me localizing for the anteromedial portal, the accessory anteromedial portal with the spinal needle. Again, coming just superior to that medial meniscus and right off the distal aspect of the medial femoral condyle, caretaken not to damage that femoral condyle. Utilizing a blade to open up that portal, as well as dilating that portal under direct visualization. You can see I'm right off the distal aspect of that medial femoral condyle and just superior to the medial meniscus, taking care, obviously, not to damage or compromise the medial meniscus. Now, behind you in the distance here, you can see the fibers of the PCL running and attaching to the medial femoral condyle. And directly in front of us, obviously, we see the ACL tear, and there's no ACL traversing across the knee into the lateral femoral condyle. I like to drill my tibial tunnel at the junction of the tibial footprint of the ACL, as well as at the posterior border of the anterior horn of the lateral meniscus. Now, why is this? Well, because we know that this is the anatomic footprint, center footprint. Also, I'll remind you the work of Dr. Arnosky and Dr. Warren showing the robust vascularity in this region of the junction between the ACL tibial footprint and the anterior horn of the lateral meniscus. Very robust vasculature that I like to utilize when recreating when making my femoral, my tibial tunnel. Now, when I place my guide pin for my tibial tunnel, I mallet this up into the femur and into the femoral condyle for stability while reaming that tibial tunnel, technique that I learned from Dr. Brian Sennett from University of Pennsylvania. But you can see also when doing this, you can see what the transtibial direction would be. So this would be the transtibial tunnel. And you can see on the femur, this would not be an anatomic footprint for the transtibial, if you utilize this transtibial technique, because the anatomic footprint, as we know, is much lower down on the wall in a high to low direction. Now, this is looking after the medial aspect of the lateral femoral condyle and the notch was cleared, the probe going all the way back, showing that we are posterior, and we've exposed the entire lateral femoral condyle. This is from the typical anterolateral imaging. Now, if I go into the notch view, again, that notch portal, this is how it allows you really to get down and look at that medial aspect of the lateral femoral condyle and the lateral aspect of the notch. Again, drilling across the guide pin. This is a flexible guide pin for a flexible reaming system that has been drilled into the lateral femoral condyle at our anatomic femoral footprint just off the distal aspect of the medial femoral condyle. Now, with a notch portal, you can see how it allows you to view exactly where that guide pin is, where your femoral tunnel is going to be placed, looking at the posterior aspect or the deep aspect of the notch, as well as that posterior articular margin. Now, this is the tunnel that was drilled along that, again, flexible reaming system. And you can see the length of the tunnel. I drill typically at least a 35 in all my cases, or a 30 to 35. And you can see that you have a nice long tunnel circumferentially intact throughout. And again, this is that notch portal that allows you this wonderful view of that tunnel. I can also see exactly where I am in relation to the deep aspect or posterior aspect of my posterior wall, and see the integrity there. I have integrity all the way around posteriorly, and then I can see how close I am with relation to the posterior articular margin. Again, that notch view, I think, is vital. Now, this is passing of the bone plug through the tibial tunnel into the notch of the knee. I'm primarily an extensor mechanism surgeon, meaning BTB or hamstring, quad, BTB or quad grafts. And so this is a BTB graft going through the notch of the knee. And now it has been pulled through into the femoral tunnel. This is looking again through the notch view, so looking directly at the ACL. Now, this also allows you to have great visualization of tapping, if that's a technique of your choice. I tap, and then also placement of your interference screw. And again, wonderful visualization of that process through that notch tunnel. And here's your interference screw placed in the femur. Now, I think, as I said before, it's very important to utilize and have in your armamentarium multiple different tools in your toolkit. So my primary approach is the modified anteromedial portal drilling technique with flexible reaming systems and an independent guide. However, sometimes that guide pin doesn't exit exactly where you would like it to exit. So I had drilled the multiple guide pins during this case, and I didn't like where it was exiting on the lateral aspect of the leg or the femur of the thigh, because I like to have it exit either in the anterior one half or anterior one third of the thigh to appreciate appropriate tunnel positioning with coronal obliquity that give me a longer tunnel. This wasn't the case. So what did I do? Since I utilized multiple different techniques in the past, I converted this to an outside-in guide, made an incision on the lateral aspect of the femur, and then used a retro reaming system under direct visualization, again, through that notch portal, which allows me to see directly onto the femoral footprint. You can see the guide pin placed here with that retro reaming guide. You can see, again, with the notch view, I can see exactly where I am with regards to the femoral footprint and the appropriate anatomy. Here is the retro reaming of the femoral tunnel. This is suture that has been passed to allow for shuttling of the graft into the femoral tunnel, and I can also see the relation of my femoral tunnel to my anatomy and recreation of that femoral footprint. And then this is the bone plug being shuttled into the femoral condyle. Now, once again, looking at coronal obliquities, this was a study that demonstrated that the transtibial, and again, this is a cadaveric study done by a good friend and colleague of mine, looking at the transtibial tunnel technique. They got 150 degrees, and then they got a longer tunnel with transtibial technique. Look in the middle, the hybrid transtibial technique, which again utilizes independent guide system. That's a newer technique that's been described. They realized a 142-degree angle and a longer tunnel as compared to the traditional anteromedial portal. To note, you get a anatomic femoral footprint with the hybrid transtibial, as you do with the anteromedial drilling. And again, traditional anteromedial drilling, you'll see there, anatomic femoral footprint. However, you have a greater coronal obliquity with 121-degree rather than 142, 150-degree graft angle, and you get a shorter tunnel with the traditional intermedial. But again, as I said, with the modified technique of intermedial portal drilling with a flexible reaming system and a flexible guide system, changing your angle to that 45-degree obliquity in the coronal and sagittal planes that was demonstrated on that MRI study, I've been able to obtain longer femoral tunnels. Here you can see on the left, there is one of my cases that the angle is actually 142 degrees, and then again 155 degrees for one of the cases. And these are again anatomic femoral tunnel footprints with independent guide that is angled in such a way to increase your graft angle, your coronal obliquity angle, and then resulting in a longer femoral tunnel. So again, this was done with that modified transtibial, modified intermedial technique with a flexible reaming system with an independent guide. So final thoughts, anteromedial, hybrid transtibial, and retro reaming are all viable femoral tunnel drilling options that recreate the anatomic femoral footprint. I would encourage you to utilize this notch portal for visualization, as you get wonderful visualizations you saw with regards to your femoral tunnel as you're working. I would encourage to utilize and master one of these techniques, the intermedial, hybrid transtibial, or retro reaming. And if it's the transtibial in your hands, because you've been doing this for many years, then it's reproducible in your hands. So you're very comfortable with that technique, and you know that technique very well. I think that's one of the most important things and takeaways to come from this. However, as I demonstrated, it's also important to have other tools in your armamentarium that you may need to perform, as you may have to utilize those on occasion if your primary technique, for whatever reason, is not working out the way that it typically does. So thank you again for tuning into this conversation and this discussion. I look forward to many more to come.